Good afternoon. I'm Rosalind Goldner, Executive Director of the UBC Faculty of Medicine Office of Respectful Environments, Equity, Diversity, and Inclusion, and I'm honored to welcome you to today's event. I start by acknowledging that we are all situated on unceded ancestral and traditional lands of First Nations peoples, communities, and nations across this province. Today, I'm in my office on the beautiful UBC Point Grey campus, which is pleasantly sunshiny today, and it is located on Musqueam territory. I encourage each of you to take a moment just to reflect on your relationship to this land. I'm an immigrant, and I'm grateful to the people of this land who have honored it since time immemorial. It's also my responsibility as an immigrant and newcomer to this land to show my gratitude to the people of this land by understanding the history of the land and to reflect on the great and tragic costs of occupation and settlement for Indigenous peoples. And most importantly, it's important, yes, to use my position to promote the rights of First Nations people in British Columbia through my support of and involvement in the implementation of the Faculty of Medicine's responses to the TRC calls to action. Today's event is part of a week-long commemoration of the BC government's declaration of Anti-Racism Awareness Week. I believe this is the second year that the government has established a week in May to raise anti-racism, to encourage people to be aware of anti-racism and to take action to combat racism in our province. In addition to today's panel, which is entitled Embracing Anti-Racism in Healthcare, we have collaborated with Providence Health Care and Fraser Health Authority to create a virtual magazine, which is dedicated to anti-racism, and it can be found on our website and on the website of the health authorities. We are also fortunate in terms of collaboration to be able to welcome from PHSA, one of our panelists, Melissa Crump. So I always I'm heartened when we can do events that bring people from many different aspects of our healthcare system. The Faculty of Medicine, I like to think of it as a little hub that reaches out to all of the health authorities, because our learners are in the health authorities environments, our faculty are often in the health authority environments, and so working together with health authorities across this province is a priority of the Office of REDI. I'm going to turn over the rest of the event to Dr. Naila Maled, who is the Anti-Racism, Anti-Oppression Advisor in the Office of REDI, and as I mentioned earlier, has been really masterfully leading us through the IBPOC Voices series, and who is engaged at many different units and departments across the Faculty of Medicine, raising awareness about anti-racism, but I think more importantly, trying to empower our community, members of our community, to make behavioral change that is anti-racist and to engage in critical inquiry and perhaps even disruption of our systems that support and really prolong racism within our institution. So Naila, please.
Thank you so much, Rosalind. Hi, everybody. Good afternoon, and thank you all for being here with us to discuss racism, anti-racism in healthcare and medical education, as we are celebrating, and I hope that we will be celebrating anti-racism rather than racism in our BC. Thank you so much for being with us. Thank you for your generosity, for your time. Thank you, my guests, for your bringing yourselves here, your experience, your expertise, and your willingness to share your wisdom with the audience. I wish that we will soon talk about Anti-Racism Action Week instead of awareness. I first also want to acknowledge that I'm talking to you from a place I call home, that is situated on the traditional, ancestral, and unceded territories of the Coquitlam First Nation. I am indebted to this land and to its caretakers, and I am committed personally to work towards reconciliation and redress as an immigrant, visibly Muslim woman, a mother, educator, and a member of the REDI office and the UBC Faculty of Medicine. But all along the process, we need the truth, and we need to learn, unlearn, and live with the discomfort of the truth, but also with the hope that an anti-racist environment is possible, an equitable environment is possible, changes are possible, because of all the humanity we share and the love we share for this land and for each other. It is my pleasure to open the panel with the indigenous welcoming offered by our guest, Tanya Dick. Tanya is a member of the Zawadeno First Nations of Kingong, Inlet, and renowned indigenous healthcare leader. She has joined UBC as its first ever indigenous nursing lead. The role was created at UBC Vancouver's School of Nursing to help guide work on reconciliation and prepare the next generation of nurses to uphold indigenous people's human rights and end racism in healthcare. Tanya has survived racism and discrimination to become a specialist in emergency and Aboriginal health. And she has been a registered nurse in BC for 12 years and received a master's degree in the nurse practitioner program at UBC in 2010, and is active in the ARNBC, becoming president-elect in 2015 and president 2017-2019. Her goal is to empower nurses to use their voice and work together to benefit both the nursing family and the health of all British Columbians. Welcome, Tanya.
Gaila Kesla, thank you all for being here. Just acknowledging I'm calling in from the Silks Territory in Kelowna, BC, visiting family and friends, and wonderful to be on these lands. Just appreciate the land acknowledgement already mentioned, and taking a moment just to think about where you're calling in from and the lands that you're occupying and present at. And just already the opening words kind of feel like stole my thunder, because that's exactly what I wanted to open with. And this kind of racism and discrimination and anti-racism action work is really a responsibility for all of us. And the days of Indigenous people carrying the load of trying to fix this problem need to be over. And really excited to be able to see that UBC is taking on and embracing anti-racism in healthcare during Anti-Racism Week, and providing space for dialogue. And I bring today, you know, my medicine that's been given to me by an elder and who's been mentoring me through traditional ways doing this work. And just, you know, in my own language, just Ola Kela Ikioktanala, that this is a beautiful day. This work is as difficult as it is, and as taxing, passion taxing as it is, and hard on the heart. It's beautiful work, and changing systems and changing minds and changing hearts and changing the ways of society that will no longer bring harm to ourselves as Indigenous people and all of those that experience racism and discrimination. I'm excited to be here for this conversation, and I just bring my medicine. I give it to you virtually, and I hope that I ask my ancestors, and I've called upon my elders this morning just to ground me in my heart and thoughts around this work. And I pass it on to you, and I look forward to the conversation. Gaila Kasla, thank you.
Thank you so much, Tanya. Thank you for this generosity, for the gift. We receive it with open heart, with a strong commitment to be together in all these struggles towards implementing, working towards the well-being of Indigenous people, their health, their communities, their growth, and also the well-being of all people on this land. Thank you so much. Today's conversation wouldn't be possible without my guests. My guests, I introduced them. Melissa Crump is the Senior Director of Diversity, Equity, and Inclusion for the Provincial Health Services Authority. She has over 19 years of healthcare experience as a registered nurse with multiple healthcare settings, such as youth corrections, youth mental health, gynecology, subacute and acute medicine, as well as infection control and prevention. As an advanced practice nurse leader, Melissa works within leadership and organization development, where her passion for improving patient and provider experience is actualized within the healthcare settings. Melissa's passions for change, engagement, and complexity science has allowed her to facilitate, consult, and share her knowledge on healthcare topics, as well as those that are meaningful to the Black community. Welcome, Melissa. Thank you for joining us. My next guest is Dr. Anas Manouzi. Dr. Manouzi is a practicing pediatric emergency medicine at BC Children's Hospital and is a recipient of the 2020-2022 Hudson Scholar Award in Equity, Diversity, and Inclusion. He leads various health equity and anti-racism initiatives within the emergency department. Dr. Salim Razak joined faculty, UBC Faculty Children's Hospital on January 1st, 2023. So welcome to BC, Salim. And after a 25-year career as a pediatric intensivist and medical education researcher at McGill Universities, he's a graduate of the University of Toronto. His research interests in medical education include the intersection of assessment and professionalism with representation, equity, diversity, inclusion, and anti-racism, for which he has the SHIRC and the CIHR support. He's the recipient of the AFMC Make On Award for outstanding contributions to equity in medical education, the Hailey T.D. Bass Award for contributions to equity in the Faculty of Medicine and Health Sciences at McGill, and the Pediatric Chairs of Canada Award for outstanding contribution to medical education. He is excited to start anew at UBC and hopes to serve in and contribute to the vibrant scholarly community in health professions education at UBC. Thank you so much for joining us, Salim, and I would like that you are a star on Twitter. So if people are active on Twitter, you can easily, just have very interesting comments every day from Salim. It is joyful to follow. Thank you so much, everybody. And thank you for being open to get engaged in this conversation. Today's conversation centers racism and anti-racism. And with my guests, we intend to move beyond just the individual racism to the examination and analysis of systems of power and domination. I believe, and we all agreed in our conversations earlier in the prep meeting, that anti-racism is an action-oriented framework to engage not only in individual changes, but in meaningful institutional change to address the interlocking systems of social oppression. So my guests, my first question to all of you, and I will have three major directions, or let's say, your lived experience, your engagement with anti-racism and how it is impacting, the way you are advocating and working. Second one is about the manifestations of racism. The third one is how we can change structures of racism to engage with anti-racism. My first open questions is how racism and anti-racism is entangled with your lived experiences. How did your awareness developed around race and racism? And how did it develop to a passion and a career commitment? Melissa.
Yeah, that's a very juicy question. I'm privileged to have been born and raised on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people here. But my family came here from the Caribbean, from the island of Wadadli, which is colonially known as Antigua. So the history of my people are stolen people on stolen land. And so, already that's a complicated history that I carry and that I've been aware of through my life, right? Being the only many times. And so, when you're the only, which probably many people can relate to, you notice things. And you're also told to continue to move forward for your family, for your people. And so, through healthcare, noticing, that we don't always pay attention to people who look like me, people who look like Tanya, Salim, Anat. And so, even though I specialized in many different areas, I realized that I needed to focus on how do we create a system where people feel safe, where they can come in the door and know that they are going to receive the best possible care, that they're not going to be harmed, that they will be listened to. And so, I really started to think about, what does this mean for me? How do I make a difference? How do I impact care? And noticing that I just can't be a nurse and not pay attention to this. This needs to be woven in. And when I heard, Tanya, that you were at the School of Nursing, my heart lit up, because we need to start this work at that place. We need to really integrate learning, unlearning, what this looks like, creating visibility right when people enter that door, that educational door.
Thank you so much, Melissa. We'll have the chance to touch on these different entanglements. I would like to go to Salim.
Thank you very much, Naila. I want to just recognize that I'm also here on the traditional lands of the Musqueam, Squamish, and Tsleil-Waututh people. And just to make it a little more personal, that since I became a dad later in life, I was older when I became a dad. Everything is about my kids. And the dream really is that they will walk hand in hand to a shared future where there's respect for rights and land in this country where they share with the indigenous people of this country. I too, my name is Salim Razak, and you might associate me a little bit more with Anas than with Melissa, but it's a little bit more like Melissa. I am from the island of Airi, which is Trinidad and Tobago in the Caribbean. My ancestors arrived there just by mistake, really. The enslavement of African people ended in the 1830s, and the new institution of Indian indenture was created, which is how my family is in the Caribbean. And I think that part of the world really gave me a very keen understanding of race from a very, very early age, and how it can be a determinant of your life and your outcomes. I've always carried that sensitivity with me to medicine, and in my practice of intensive care medicine. And in medicine, the examples are everywhere. They're everywhere. You know, I'm sort of thinking about kind of like little things rather than big things. Little things like how long we spend with a family in comparison to another family. How we use words like, oh, this family is very articulate, which is a code word for they're like us rather than different. My work really began in my own local environment, thinking about actually Indigenous children in my own environment. And you know, I'm reminded of an example, and this is the last thing I'll say. So I once looked after a patient, I'll call her Savannah.
Yeah.
She was a Cree patient, and she was very critically ill with a cancer diagnosis. And I remember dealing with the family, and what was impressive to me, I was young at the time, didn't know very much, was that I was dealing with all of the women in the family, actually. And they kept calling everybody the grandmother, and there was quite a few. There was at least 8 or so. So it couldn't have all been grandmothers, but they kept calling them all grandmothers. And they all had to have their say in the care of Savannah. And they did not come from a place of trust with healthcare. And the first thing for me to learn was to sit there and listen. And the second thing for me to learn was that the building of trust takes a very, very long time, maybe even generations, and that we have a real place to move forward to that comes from a very, very bad past and present, particularly with respect to Indigenous people. And that has been the journey that I have taken, that I hope to continue taking here in Vancouver and in British Columbia.
Thank you so much, Salim, for this hint. I would like to go to Tanya. I'm sure that in your introduction, you mentioned the entanglements with but I'd like to hear from you, like we shared it before, you know, what brings you to that space? The personal.
Yeah, it's a good question. It's a deep question. I think coming to this space is one thing, but being forced into this space is a whole other. I mean, as an Indigenous person, I'm First Nations from the Zaudeno First Nations Band of Kinkom Inlet. My parents are both survivors of residential school. The kind of legislation, the Federal Indian Act, all of those policies that my parents have had experienced and created residential school are still kind of in place. You know, they really are in place and they haven't been removed. And you know, moving through my life as a young girl and young lady, it was kind of normalized. I didn't really kind of think of anything other than life's hard and I have to fight hard and I have to get smarter at this to be able to maneuver through this landmine of kind of racism and discrimination. But as I entered my professional career and was able to kind of label things a bit more and articulate things a bit more and understand and unpack it and realizing, you know, this is more than inappropriate. And having, you know, earlier in my career, reading about the Brian Sinclair story out of Winnipeg and the Joyce Echaquan story. And then same year as the Brian Sinclair story, my own aunt, who, you know, in our Indigenous communities is like a mother to me, was accessing an emerge department with her husband because she was kind of acting weird, and they just said she was a drunk Indian, she needed to sleep it off. And as a result, she died from that visit. She actually fell in the bathroom and hit her head on the tub and had a significant head injury. And each assessment point, whether it's the nurse, the point, you know, at the point of care, the nurse, the physician, the nurse again, they threw her in cells because she was just acting up and she was under the influence. In the cells, she started getting sicker, so they brought her back to emerge. And then she walked out the door and somebody found her in a ditch. And it just was this unbelievable horror story that, you know, one of the most important women in my life had to experience. And That was all assumptions all the way along. And we counted the professionals, whether it was physicians, nurses, care aides, police, ambulance attendants, even the MOA. There was 27 people she crossed hands, and every single one of them said she was under the influence of alcohol. That assumption was so strong and so consistent. And come the toxicology and the inquest, there was no alcohol in her blood system at all. She just had a huge brain bleed that killed her. And with the proper interventions and had time to medevac her out, it was a preventable death. It was an absolutely preventable death. And that really changed my life. Like, hearing the stories and then living the stories are two different things. And I've always been kind of an activist in a fight mode around that, around racism and discrimination, specifically in health. My mom came out of residential school and went into nursing. She knew the health and welfare and overall status of health of our people was not in a good place, and she wanted to be a part of that solution. So she threw herself. She was a graduate of UBC as well, allegedly the first registered nurse to graduate from the UBC School of Nursing, and just was an activist. She was in the Red Power days, and she fought this fight in healthcare, and just witnessing and seeing that as I grew up, it was kind of inherently hardwired into my brain and my way of thinking and seeing and moving in the world. And looking back on it now, and my mom's well beyond retired and tired. She threw herself into out of residential school into this work wholeheartedly, and she didn't have the parenting skills that she required or that would normally be groomed into her through her community lived experience, because she was taken away at the age of 6, and she never was a mom. She didn't know how to be a mom, and I had to experience that and move through the world and kind of learn from her from a distance, as if it was from a stranger, not a nurturing mother. So not having those kind of foundational pieces of my upbringing and creation of that brain and passion to step into this work really looked at her as a professional and lacking that kind of motherly and fatherly figures, because that's what residential school, and that was the intent of residential school. It was the absolute intent of residential school. It was the breaking of the system, family systems, and taking that away from mothers and fathers and aunties and uncles to fill their roles. And so I feel like being the first generation out in that intergenerational trauma is quite deep, and just recognizing it and becoming more aware of it and kind of utilizing it in a way where, it's not a chip on my shoulder. I don't become the angry Indian. I really want to find some solutions. I really want to not carry what's not mine. I really want to know what's in my backpack that's mine to carry, and have conversations and dialogues professionally where true accountability is and whose responsibility is whose. And that's the exciting part of these types of conversations. And the more kind of blind spots we clear up, and the more we kind of give some clarity to those that are within the system and provide services within the system, the easier our lives will change as Indigenous peoples. We will stop dying preventable deaths, and we will become healthier people, and we will continue to contribute to society if we are allowed to do that, or if we're permitted and come out from underneath this racist, discriminatory societal existence we are in right now. And I'm looking forward to that. And I have a lot of belief, and I have a lot of hope, and I hope I can pass that on to the next generations following me, because they say it's going to minimally take 7 generations out of residential school to really kind of find ourselves again. And allowing myself to be patient with that, and allowing myself not to take on too much and burn out and get PTSD just from trying to survive my own day-to-day life is really, really important, because this type of stuff can really, really make you sick from a mental wellness perspective. And knowing that not only those on the call and those around and within the system have a responsibility to patients or clients, or who are we delivering services to, but to our colleagues, to those around us. And I think I've survived and moved forward because of the people I've surrounded myself with, the non-Indigenous peoples and my colleagues that I work with, who not only hold me up, but lift me up in this work and support me. And that in itself is so vital. And I think we don't talk about that piece enough. I think I could go on and on, but that really is where I'm at. I feel like it's a forced issue for me. It's either fight or die, in this world. And I want to live, and I want to thrive, and I want my children to, and I want the children's children to. And I think the change is possible, and I have belief in the change. But when legislation and policies and systems are completely against this vision in my head and in my heart, it's daunting. It's really, really daunting. And there's a lot of work to do. There's so much work to do. We are still under the oppressive system that created residential schools and Indian hospitals. I'll stop there. Thank you so much.
Thank you so much, Tanya. I don't think I have enough words or the correct words to express the comfort, but I am sure that the pain that is part of these experiences, the daily challenges, struggles, the daily remembrance of these steps, life experiences, as painful as they are, but I think they are also a source of motivation, a source of engagement. It's the catalyst of this dynamic engagement with the sense of hope. And that's why I really appreciate that you are sharing with us these personal stories, because I think the personal is what impacts us in the way we are so committed to anti-racism. Dr. Anas Manouzi, your experience also, I think, and your commitment to equity, diversity, and anti-racism, and particularly I focus on anti-racism today, is also entangled with lived experiences of a son of immigrants in Canada. Yes, please.
Yeah, thank you. First, I'd like to thank Tanya for what you just said. I think the story you shared is extremely powerful, and I hope during this conversation we'll be able to unpack some of these, because I think you touch on legislation, you touch on bias, you touch on discrimination, you touch on trauma, what it is for someone as an emergency physician needing to care for someone who had your experiences coming into the ED. What does that mean in terms of what can I do differently to recognize all of the previous experiences you had? So thank you so much for bringing this up, and I hope we'll be able to talk more about that. I think my journey to anti-racism is a bit twofold. One is self-centered, and another, and then after is recognizing my own biases. And I was 15 years old when 9/11 happened. So I was a Muslim boy in Quebec. I think my perception of who I was changed to the perception of others very quickly. And I think that shaped a lot of my adult brain development in terms of understanding the bias and discrimination and the look in people's eyes, and the slight comments, even up to this day, like, oh, you have a terrorist beard, those small things do matter and do change. And I'm from Quebec City, which is also where I live just a few blocks away, where there was a terrible shooting in a mosque, and killed many people and wounded many people in my community. So those shaped a bit my self-centered perception around racism, and also the legislation aspect, Tanya, that you were talking about, where being visibly different, visibly Muslim is seen as a threat, and now embedded in legislations to deny equal protection under rights in Canada. So this affected my vision. So I moved to BC 11 years ago, and I had the chance of marrying a fantastic person who happens to be a anti-racism educator in the public school system. And when she was explaining to me what is racism of low expectations in the education system, she was asking me, what about you in healthcare? And I had a moment to say, no, I'm at BC Children's Hospital. We're pediatricians. We love kids. We're not racist. It's not happening. And it really took some time for me to really understand my own biases and see what I was not seeing. And I think that led me to be much more engaged in trying to change and trying to recognize the experiences that you're describing, Tanya. And I think some of the work that I've been trying to do in the emergency department is to stop trying to expose the stories in our emergency department, in our hospital, but just to listen to all the stories that are already out there and act as if they are actually ongoing and happening in our institutions, and act on them instead of always being in the research mindset of let's explore, let's document before doing anything. I think we need to stop, questioning whether climate change exists. And we just need to get to do the work. So that's a bit how my experiences led to what I'm trying to achieve today.
Thank you so much all for sharing your personal stories and narratives. And as I always say, that we can change what we don't see. When we speak about anti-racism, I need to highlight that anti-racism discourse places power relations at the center of a critical analysis of how race, with its intersections with class, gender, sexuality, religion, immigration, indigeneity, immigration status, ethnicity, sexual orientation, are embedded in institutional structures. And you mentioned it, I think all of you see these structures, but for this question, I'm asking you to be our mirror. How does racism manifest in ways that are subtle, visible, invisible to most people, but visible to people who can spot them, who live them in healthcare and medical education? I would like to start with Tanya, particularly regarding Indigenous health.
Thanks. I was hoping not to go first on this one, but I'll jump in and answer as best I can. And how to, I don't know, for me, I just had previously the experience to participate with the BC Nurses Union in negotiating their collective agreement and approaching them with some Indigenous specific language, and actually being able to bring that to the table and hash it out, and then move forward with the bargaining team, and then actually have the members ratify it for with that Indigenous specific language in there. And that's a really highlight of my career. And just realizing that a collective agreement, as important as a collective agreement is for nurses in their practice, I've never seen myself in that collective agreement. It's never supported me to be my authentic self, to show up and just be me as the best Indigenous nurse that I can be, or best nurse that I can be. So that was profound for me. And when those types of kind of systems, or those types of things that the system relies on, doesn't reflect anything Indigenous, it's not going to be a part of the conversation. It's not going to allow that system or management or executive or any level of leadership to participate in the change that's required, if it's kind of that silenced, invisible, blind spot. So really realizing the importance of utilizing the legislation as leverage to say, hey, this isn't just a feel-good thing and right thing to do anymore. This is the law. We are legislated under the Declaration Act that Indigenous people have rights. And what does that look like through our practice? And it's been a difficult process. And if you asked me 2 years ago or 5 years ago if I'd be having this conversation, I'd probably laugh and cry at the same time, because I wouldn't think so. So seeing it kind of manifest against me as an Indigenous nurse or Indigenous professional is just kind of strung through all of those levels of policy and procedures and collective agreements and contracts. and realizing the importance of us as Indigenous nurses need to create a table and have space and voice to be able to create Indigenous specific language in our collective agreement, in the policies in the flora that we service, et cetera, et cetera, et cetera. And it's not ours to do and create. It's now the real work happens for management and people on the floor who run these systems. If we need cultural leave, or we have these seniority issues around hiring processes for Indigenous peoples in Indigenous communities or for Indigenous clientele, there's some kind of pathways for that to happen now. And fighting for that, I came out of that with a lot of blood and sweat and tears, and I definitely will have some scars from that. So it's a real indicator that the system and the resistance and the pushback and the inability to kind of buy in and kind of create a flow for this kind of work to happen was profound yet again. So every kind of success I feel like I have in kind of this policy level or systems level, it feels like a win and a coup, but it comes with a lot of band-aids and a lot of loss and a lot of grief and a lot of pain and a lot of scars, I guess, so to say. I'm not sure if that answers your question, but I really feel like the majority of things that manifest makes us invisible, makes us silent. And that's been for generations. And we're kind of at this stage now where we're realizing, not only us as Indigenous people and professionals are realizing we do have space, we do have voice. This is our practice. And we should be able to practice amongst our standards, within our standards as best we can, and be the best possible person, and not be minimized and shut down and told we're less than and made to feel less than through attitudes, beliefs, policies, et cetera, that makes us silenced and invisible, because that still exists. And just that manifestation of continued oppression, that silence, out of sight, out of mind oppression, is how it really manifests for me. And I just try to pop up everywhere I go and say, hi, I'm right here and I'm not going anywhere. What can I do? And I want to be a part of the solutions, and we're going to do this together. And hopefully we can continue to do that. And I've moved beyond having safe spaces now for our voice to accountable spaces. We have to have accountable spaces now. This is not mine to carry. This is not mine to convince you. This is not mine to change. This is on the non-Indigenous people to really change the system and look at that and hold that responsibility and accountability in their practice and their leadership and their vision. And yeah, so I'll stop there. Thanks.
Thank you so much. Melissa, how does, before we tackle anti-racism, and I hope we spend more time on anti-racism, just a few examples. How does it manifest? What are the invisible things that maybe, in the mainstream healthcare practices and services and education, we see them as normal, so they'll become normalized. But at the heart, they are completely biased, discriminatory, and racist.
Yeah, absolutely. I think there's a few examples, right? I think there is like the eraser or the omission of things in our policies that acknowledge racism and discrimination in people, right? And I think when I go a little bit deeper, right, to like the ground and the floor, it's the conversations and the assumptions and comments that are made when people walk through the door. I guess an example I can give is the fact that if I need to access care, I can't go in my sweatpants and t-shirt. I need to get dressed up close to Sunday best in order to be taken seriously. And I need to bring, if I work for healthcare, I need to bring my badge as well, right? So it's the fact that some people get care and some people don't. Just by looking at them, we determine that. And what kind of care, whether we believe them, how many times they have to ask for something. Do I need to ask for pain medication twice? 3 times, 4 times before someone's going to do it? Or do I only have to ask for it once? It's whether I'm followed up when I have an illness. Do you remember me? Do you remember who I am, or am I bed 1, bed 2, bed 3? Can my family come in? Or am I the family with like the 10 people who follow behind me? What language do we use? So it's all of those things that we see that are these passing comments, right? Things that we've reinforced that we just take as normal and everyday occurrences that has huge impact. That doesn't make me or someone else want to come back. You know, racism kills people.
Yeah.
Because one, you don't get care, or you don't want to come back, or you just get bad care.
Thank you, Melissa, for these powerful examples, because you remind me sometimes you open wounds with this conversation. I admit at a certain time, I felt very uncomfortable with my veil. I felt that I feel like awkward, particularly when I go to hospitals or I seek healthcare. I remember I used it to remove the veil and put just a hat. Good that we had, cold weather, because I would see the difference in the treatment. I say it because I felt it. I know that I was sometimes even dismissed. My educational capacities were undermined, never looked at me as a well-educated woman. So I was always positioned on the margins because I looked a certain way, I dressed a certain way. I'm sure that many examples are here, but I'm sure that Salim and Anas will add to these manifestations of racism that sometimes most of the people, they are not even noticing what's happening surrounding them. Anas.
And no, thank you for sharing what you said. Yeah, in pediatric emergency medicine, we know there are many ways racism is embedded in the care. There's excellent data from the US looking at hundreds of thousands of visits to the emergency department and how Black children with appendicitis are systematically receiving less pain medications than non-Black children. There is, in the clinical decision tools that we're using, up to recently, we were using this tool called UTI Calc, which was a tool used to predict what is the risk of a child with fever, younger than 2 years old, that they would have a urine infection. And it would help us decide, I should test this child or not test this child. And there was a race coefficient factor, including a Black race as a biological factor, that made it less likely for a kid to have a UTI. Therefore, systematically, we were testing fewer Black children because of this tool. And we're sending them home saying, oh, come back when your fever reaches 5, 6, 7 days. You most likely have a virus. And this was changed up to just a year and a half ago. And I was trained using this tool and we never questioned it. We saw it, but we never had the analysis or the framework to really question those things. And I think those are the type of conversations and the type of tools that we need to empower our colleagues and ourselves in terms of challenging the status quo. Other ways things are invisible is the triage system in the waiting room. So we have a standardized triage system called the CTAS scoring. And when you come in the emergency department, we ask you a few questions and then you're ranked 1 to 5, the most acute to the less acute. Great study out of Alberta just last year showed that systematically Indigenous people were underscored for the same presentation. So exactly what Melissa, you were talking about, how, you need to come dressed up, show yourself in the best way, because even if it's a standardized tool, the way you look, your ethnicity, your race will impact the way the clinical outcomes of those tools, and to recognize that race matters and we're not colorblind in the way that we practice medicine needs to be not a controversial statement. It needs to be the status quo, that we need to acknowledge that this is happening.
Thank you so much, Anas. Salim.
Thank you. Very powerful examples. I think I'll focus a little on education rather than clinical practice, because I think the examples that have been given are perfect and wonderful examples. I have to preface by saying, I'm older and I belong to the generation that behaved a little. We thought that we could change things from the inside by working within the system, and it didn't really change. And I think it's a real statement that there's a need for kind of disruption, dismantling, all these kinds of things. And I say that to you because, and there was one other thing I wanted to say as well, which is, that the positions that we occupy are really important, right? So, and I mean this social positioning. So as a brown person, I can be co-opted into white supremacy by not recognizing by the model minority myth. Let's start there. That's a simple example, and which works until it doesn't work, until you misbehave. And I have lots of scars to kind of talk. We can all trade scars, but we won't do that today. So I'm going to misbehave a little because I would not have been able to say what I'm about to say in 1996 when I started, even though I knew it in my heart to be true. So medicine is based upon white supremacist knowledge systems. Okay, it is also profoundly patriarchal. In fact, we're still teaching that women present with myocardial infarction symptoms atypically in comparison to men. Which is a social choice. And of course, we're going to notice outcome differences in the care of men and women with myocardial infarction. And I learned about that mythical 70-kilo white male. And in fact, the whole 4 years of pediatrics could be boiled down to teaching about how, children are just deviants from that. And I'm glad that they're deviants from that, because they're good deviants. And it's also cis and heteronormative and ableist. These things permeate the knowledge systems. And here's an example. So we have a journal club where we discuss race as a risk factor for, let's say COVID. There are lots of good examples of that. To label it as race, situates the difference inside the person, rather than in that person's relationship to a highly unjust and racist society, which is actually where the social determination is happening. So the right word is probably to say being racialized as, or experiencing racism as, that is the proper risk factor. And, we talk about these things in Journal Club and it becomes normalized, and things pass peer review without anybody looking at them, because peer review has its problems with systemic racism as well. I think Anas brought up another point, which is kind of the notions of racialized race correction, basically, which is a practice that must end, I think. This is the idea that you might have different normal values for blood tests or something, depending on race, or, like a tool, as Anas described, where race is in there. Because you know what the history is of all of that? Those things have been used to perpetuate inequities, actually. And there's many, many examples of that. And I think we have to end race correction. And there's still many examples of race correction. I haven't checked out Cerner yet. Okay, but in the United States, with the drop-down menus that are offered, like when you make a diagnosis and they're offered, some of those are based on racial algorithms. And my plan is to check out Cerner to see if it also does that. Cerner is the the electronic health record here in British Columbia, just for those of you that do not know. I also I wanted to bring up just how insidious it is. Okay, so we have pulse oximeters in intensive care medicine. You know, these check out the oxygen levels in blood, and they were tested mostly on light-skinned individuals, so that they're actually can underread by 2 or 3. Some of the newer ones don't do that, but there's a long history of this going on. They can underread by 2 or 3% in dark-skinned individuals. All of these things add up, you know, and there are examples of systemic racism in perioperative care in pediatrics. There's a paper that came out recently that sort of showed, you know, mortality outcome differences between Black children and non-Black children in it's rocking the pediatric world right now, actually, in perioperative care for very mundane surgeries like tonsillitis, you know, things, just normal kinds of things that happen to children. I'm reminded of a paper by Dr. Nadine Caron. She was one of the authors on it, which looked at the differences in liver transplant diagnoses, which hints at systemic racism in the transplant allocation process for Indigenous people here in British Columbia. That Dr. Caron is at UNBC. I do hope to meet her one day because it's a great paper. And, you know, I think what all of this does is that it's about casting a white gaze on people, right? You know, they become the other, they become deficient, and that is sort of what we teach. The last thing that I wanted to talk about was some intersection. This is really the last thing. Intersectional issues, right? You know, issues related to sort of your race plus something else like gender and sexuality and so on. So I'm a LGBT person. I identify as a gay man. I'm obviously a brown person, and I have had the experience of thinking about safe forms of difference versus non-safe forms of difference. And let me tell you what I mean humorously, perhaps slightly humorously, but with a tinge of darkness. You know, in Montreal, where I was for many years, you know, gay got you invited to the parties. Muslim, not so much. And I think that we really have to confront kind of like how those forms of difference can also become quite whitewashed, right? And, you know, I can talk to you about the whiteness of pride parties and pride parades and so on, and how, you know, how it's hard for, as a brown person to participate in, you know, subcultures such as that when other forms of difference and oppression are not recognized. What do we need to do now? We need, you know, I'm so jealous of just this generation now, because we're talking, you're saying, and perhaps what we can do is look at things like curricula and what we're learning and dismantle these harmful forms of knowledge that have really just brought people to harm in many ways. That the little examples I gave you are really just little examples. They're much bigger ones. And we could really, you know, dismantle those things together.
Thank you so much, Salim. I know that we can spend hours and hours discussing the manifestation of racism. This is just, you know, a few hints, few examples from our lived experiences, particularly, and from your eyes as practitioners in healthcare. It is so important that we engage with anti-racism, first of all, with the humbleness that our angle is unique. We cannot see everything, and we need to learn, and we need to unlearn. And in this process, it is extremely important to open spaces where we can share these experiences. I'm sure that at a certain time, people are still uncomfortable when talking about white supremacy or white fragility or decolonization or indigeneity, or even sometimes to the point that even acknowledging the land might incur a certain discomfort. This is the time that we all get into the space where we all need to open these wounds. I have a friend who's an indigenous writer, and she speaks, we need the truth before the reconciliation. We need the harm, the pain, before we move with the strategies. Thank you for your wisdom, for your sharing personal stories, for pointing out to certain invisible ways that we, most of the time, we don't know. I'm mostly an advocate for literacy around the needs among the populations. I was fortunate to work with the Syrian refugees. And these people, many of them were diagnosed with the terminal cancers. They didn't show up to their medical appointments. I was on the emergency contact for about 100 of them because none of them speak English. And I was called by the officers, this person didn't show up. And when I called them and I contacted them, I had that bitter smile on their faces. Why do I need to go? They don't even look at me in the eyes. I sit there for 10 minutes. They talk among themselves. I don't understand anything. I'm prescribed the medication that I don't know even how to use. And we have so many experiences of that. People falling in the cracks because we didn't take the time to learn about them. We still have about half an hour to engage with hope. This is absolutely depressing, draining. Fear, it's kind of triggers fear. But I think all of us here in this space with the audience coming to us, as Tanya presented that, we are here, we will stay here, we will continue the work, we are not giving up. Because you are practitioners, you know better than anybody else, better than me, you know. What strategies do you suggest to move forward with an anti-racist agenda? I give you here the three things: policies, regulations, clinical practice, patient care, medical education, and research. You can choose whatever you want to talk about. Start with Melissa. Whoever, if you want to, yeah. What should we do, for example? Yes, Anas. Whoever feels comfortable starting the, yes?
Yeah, I can start if that's okay, Melissa. Yeah. I think a simple example that you just used with Syrian refugees and the language barrier is the use of translators. And I'm fortunate in my emergency department, our institution invested money that we have access to multiple live translators that we can use at the bedside seamlessly. And what I try to explain to the trainees, which brings also the aspect of education, is it is probably going to take you 2 to 3 times the amount of time to complete that interview with the use of the translator. But this is an essential intervention to just reach the same clinical outcome. Taking that extra amount of time is what will help that patient reach their full health potential, which is what health equity really should be and is. I'm also, and I think the other aspect I want to talk about is money. I'm a salaried physician, so for me, taking 30 minutes with that patient who needs a translator versus 10 minutes for the native English speaker, that doesn't impact me financially, but in most clinical settings, it will do in the emergency department, and it will impact the care of patients, knowing that there is a language barrier. They will stay at the bottom of the list, and people will not pick that chart as quickly, and it is something that we need to recognize. The other aspect also about money that I want to talk is what Salim was talking about, is that intersectionality. We prescribe medications to patients and we never question whether they can even afford them. We know Canadian data, 10% of families can't afford the medications we prescribe them. in my sitting, we're working on a QI project when we look at one of the most common antibiotics we prescribe is cephalexin, which for 20-kilogram kid, the liquid formulation would cost $110. But then when we look at who are the people who actually cannot afford that medication, and we look at the data, 17% of non-immigrant, non-racialized people in British Columbia don't have access to private drug insurance, 17%. If you look at racialized communities, that go to 30 to 40% of new immigrants and racialized populations don't have private drug insurance. So they need to pay that $100 out of pocket. So we don't talk about those things, and they're not visible from the get-go. But when you dig deeper, we realize the intersectionality of racism, of how it goes from the type of jobs that you have, the type of insurance coverage that you have, the type of bias you will get into care, the ability to, Celine was talking about medical education. Our textbooks looking for rashes for pediatric patients, and rashes is one of the things that I do the most in the emergency department. I don't have a textbook that looks at kids with dark skin tone. 95% of the pictures in those textbooks are of a child with light skin tone. And we have a surge right now of a group A strep and kids that come with scarlet fever. The rash looks quite differently in a kid, but I don't have the tools to help me recognize that. And those are things that we need to talk about.
Maybe I'll go next if that's okay. Is that okay? Yeah. I'll focus again on so there's lots of hope, just personally for me, what brings me through is to see a new generation coming through and fighting and changing things, and it's really, really good. I think one of the fundamental things that needs to change in education, medical education. So what Anas has been just telling us there has been stories, right? Stories of patients and so on. And I think that a patient's story is a very, very different thing than a medical history, actually. It's actually a different, literary genre. And a medical history is all about the power of the profession to call into existence a disease, actually, and then treatments and outcomes, and that's important, and there's a place of it. There's a place for it, I suppose, in what we do. But to hear a patient's story lets you know, which is a dialogic thing, talking to them, where we risk also being changed by hearing the story, and understanding what it is like to an example is my mother was on Coumadin when she's passed now, but when she was alive, she never had a normal INR in her life. Every Monday was to go get a blood test, right? And it was a joke. I mean, we would go line up here to give the hospital card, then we have to go to the third floor, and then we have to go here and there. And thinking about how that model of care might be for someone who doesn't speak English is something that we can do. And the point for me to tell you that is to really say that in education, the examples at the micro level are there all the time. So that example I gave you is an example of blood tests in one little institution. And if medical students and health professional students can be encouraged to notice those kinds of things and be in an environment where it is safe and brave to raise those issues, they can be part of small changes like that, that really show them and help them develop the skills in changing. And I would say that the skills really, I go back to kind of Paulo Freire, Brazilian educator, who really talked about critical consciousness, the idea of appreciating and reading the world, reading these injustices in the world, but then also committing to act. And I think that that's like a major thing that we're trying to teach people. Freire also talked about pedagogy of love. I think that we have to show a kind of a love for where everybody's at in this, as we're, you know, as teachers, for instance, where everybody's at in these appreciations, but not by not talking about stuff. We have to talk about things. We have to talk about, you know, the 35-page psychiatry entry questionnaire that you have to fill out in order to get a consultation in psychiatry, and how it may not be good for people who don't speak English. I think I'll stop there, but I'll just say that the future is bright. We have lots of help coming from students who are pushing us very hard to move forward in all of these things.
Thank you so much, Salim. Thank you so much, Anas. I would address Melissa and Tanya, particularly with your deep and strong and long experiences as nurses, particularly asking you, how would you see changes that would, for example, in the nursing environment? I am very aware personally that our nurses are overburdened, are tired, are going through a lot from the part of the system that puts on them a huge load to carry on, and at the same time, the expectations of the population that come and seek their help. That's why we have a huge number of people quitting that job. So from your perspective, Melissa and Tanya, how would we particularly strengthen this field and this area? And how can we provide support, and how can we create spaces where hopefully, more and more people will be interested in that area, in that field? Of course, you are open also to talk about the general system in general. We go with Melissa? Okay.
Sure. I know Tanya's going to have some wise words for us that I can't follow. So, and I'm looking forward to hearing them. What I've learned, I think, I never thought we would even say the word racism in healthcare, right? I didn't think we'd say the word white supremacy, white fragility. None of those words were ever spoken when I was in nursing school. We didn't talk about it. And it's interesting to see now where we are starting to push around anti-oppressive language, anti-oppressive ways of being, deconstructing. We need to deconstruct how we teach nurses, and how to be more inclusive in learning, right? And being curious around what does this look like in real life, in practice, rather than relying on not questioning the way things are currently. And I think, Salim, you alluded to, we have a new generation where they are instantly already starting to question and to push back. And my hope is that nursing education will start to move in that direction. And I am hearing an openness, but I think there's still a lot of room to move when I look at the curriculum, right? And I'm a nurse through and through, right? So for me, even to say this is like, we do need to shake it up. We need to change this, because we aren't providing the care we have idealized or said we are providing when we continue to have blinders up, when we continue to marginalize voices, people, through our care. And I think that when I look at the system and being in the system, I'm hearing from nurses that they want to do this work. They didn't even know. This has been invisible to them. And a lot of this is new. So how do we just provide the space to start talking about it, to make the invisible visible, so that now we can start to walk a different path? And that's what I spend a lot of my day around, is just creating that space, that conversation, having people explore those worldviews that they have held tightly, the ideologies and paradigms and pedagogies that we hold tightly in nursing that now need to be broken and rebuilt to look different, building it on our Indigenous teaching, on our land, on our people in general. And how, and I spend a lot of time like working with leaders around, you know, your role in this, modeling it, walking it, deconstructing, saying it's possible when others are saying it's impossible. That's your role as a leader, to step boldly into that. And how do they do that? How do they start to not question when people of color and people who have been historically placed upon on the margins are saying there needs to be changes? So looking at those processes, those policies, and those procedures that constantly, you know, oppress. There's lots of work, lots of opportunity.
Thank you so much, Melissa. This is so powerful in terms of bringing up that opening conversation, questioning, discussion is at the heart of this work. Nothing is normal. We need to avoid this familiarity, to turn the familiar unfamiliar, to be able to question that. And Paulo Freire is a great scholar, educator, that if you look at his work, it will be very inspiring. Tanya, from your perspective as an Indigenous nurse, a lead, an advocate, passionate, with your lived experience, with your hope too, how would you see the changes happening?
Thank you. I think I really agree with Melissa's comments on that. Nurses are really wanting to be, what do I do? What can I do? I'm constantly being reached out to, called upon, tweeted, emailed. Thank you for your story. What can I do? And so the desire, I feel like the desire is there, but that unpacking and moving from the normalization of this ugly system that has created all of this harm and death to Indigenous peoples. It's a difficult job. And where's the leadership in that? Who leads that? Who, like, there's got to be some strategic approach to that. And part of my, I feel really proud of part of my CV is participating recently in the past few years. It's probably been about 4 years now. First Nations Health Authority contracted with HSO out of Ottawa to write a cultural safety and humility standard for BC. And it originally was for health systems, and then we kind of broadened it to all systems, like just anything that from HR to hiring practices to union, like it really, we kind of tried to build a step-by-step process to help people and organizations and leaders implement this process into their day-to-day lives. And then I feel like that took us 3 years, like being an author of that with a handful of the technical committee and some experts and leadership. It was painful. It was absolutely painful drawing that out of us. And when it becomes a document sitting on the shelf and it's not utilized, that's kind of a piece that really is frustrating for me. And then looking back on, you know, the Truth and Reconciliation Report and their recommendations, we talk a lot about TRC, we talk a lot about the missing, you know, the 215, we talk about residential schools, but at the practice level, what is the conversations and how is that unpacking? It doesn't quite get to that point, it feels like. You know, we just recently in British Columbia, it's been 2 years now since the release of the In Plain Sight report, which is an investigation into Indigenous specific racism, which I had the privilege of being a part of that investigation and a part of kind of helping with the authoring of that recommendations and then implementing the recommendations through the task team. And did we get anywhere in the 2 years after that report was released and the measurables in place now looking at that? So we keep laying these tracks and we keep kind of drawing on the blood that's pouring out of us and pain that's coming out of us from our lived experiences to help guide. And when there's no buy-in or there's no kind of jumping and putting your wheels on the track and let's make your life easier, like it's all laid out right here. and you can tweak it as you need to fit you and fit your organization or fit your team or whatever it is. And then I'm just looking over on the bookshelf, and parts of things that I've been author of, like the little the pile is growing, and the Missing and Murdered Indigenous Women and Girls report and recommendation is also on the shelf. The Royal Commission back in the day is on the shelf. Like, all these things and data is present. We know what's wrong. We know the stories, and we keep going back to the Indigenous people and asking more and more stories. And I was recently at a clinical nurse specialist conference here in Kelowna a couple of weeks ago. And one of the ladies stood up and said, I really consider requesting more stories from Indigenous people for my practice violence. And that was profound for me, because we're beyond that. We don't need any more stories. We need the action piece. We have so much to draw upon and help lead us in our practice to change the systems that are creating harm to our peoples. And so I guess for me, I've been pretty high level for the last 5-7 years of my career, and participating in the creations of these kind of pathways and frameworks, and now work at the government level and feel like I've kind of infiltrated, and I'm, here I am. I'm not going away. I'm still going to be here. I'm still going to say these things. And yeah, so I feel like that's a little bit of a negative spin on the anti-racism action piece, that we are doing things, but the buy-in and the pickup and the running with the ball, like we hand a baton and we're trying to make your job easier, when really it's not my job to make your job easier around treating us better and treating us as human beings. And so that's a frustrating part for me. And being an Indigenous lead in the nursing program at UBC, I worked with the union and I got to visit every school of nursing in this province. I could have went anywhere, but because of UBC and my experience as an Indigenous student, some of my most profound and horrific racist experiences came from that school. So my choice was to stay. I'm going to be a part of the solution. I don't want the person following me to experience that. And we're going to make these changes, and we're going to make them together. And then kind of being able to fight for and create the position internally. There's not pushback, but there's it's almost like backs turning to you and ignoring the position or ignoring the opportunity. And I think for true anti-racist action to happen, there needs to be support and movement and mobilization around these things that are happening, that resources are being poured into. You're going to create an Indigenous nursing lead position in the UBC School of Nursing, and you're not going to utilize that to help move this agenda forward. And I have to keep initiating and still be there. Hi, here I am. I'm not going anywhere. I'm still going to say the same things over and over again. Hopefully somebody picks it up. Just being aware of that piece, that there are a lot of anti-racist actions in place. There's a lot of anti-racist resources and investments in place throughout our system. And seeing that, and if it's not touching your practice or your day-to-day, still support it. It needs that support. It needs that buy-in. It needs that projection. It needs that voice. And we have to link our arms on all of this. There's so much out there already, and we're not getting bang for our buck. We're not getting the impact that we should be. And I think I'm just realizing that whole patience thing again, and having to say, okay, I'm here. We have this position now. Let's keep working. Let's keep working. Let's keep working, and not expecting everything to change overnight, because it's not. It's going to take generations. I'll stop there. Thanks.
Thank you so much, Tanya. All I think your comments, they bring it to light that anti-racism is hard work. It is also hard work, because it comes and it's connected to our, lives, commitment, experiences. It is always also important for me to highlight that, to emphasize that racism is neither to be subsumed nor separated from discussions of sexism, ableism, heterosexism, racism, and anti-Indigenous racism. It is extremely important that these conversations are needed, but also actions are required. And we are all responsible for that, each from our own positions. A lot of work is needed, and I think you mentioned that. A lot of work is needed, but it can't be done in silos. fragmented and in isolation. So hope these conversations enhance our solidarity, dismantle hierarchies, open spaces where we can meet together. And I would suggest to do like a day, a symposium, a day where all the health authorities gather, First Nations Health Authority, physicians, nurses, educators, they gather and they sit, but also it is an invitation also to the leaders who have decision-making power to change a lot of policies regarding hiring, representation, tokenism, committees working on these issues. It is very important that we end the session, that we are all hopeful, that we are all seeking to have better place for all, for all of us. But I think the work is not only the work of people of color, it's not only the work of indigenous people, it's not only the work of, the least powerful in the circle. It's the work of everybody in this space. Thank you so much for accepting our invitation. Thank you for your wisdom, sharing your personal stories. I have one question because usually I open space for audience. Unfortunately, the time I wish I could spend hours and hours with you. One, for example, is asking, people are afraid from these learning and training regarding, these EDI workshops, anti-racism workshops. They come with a certain fear. I have my answer for the person, for I think Alexandra, but I let one of you just, answer. Salim.
Yeah, I saw it in the chat, and it's something I actually think about a lot. I think the first thing to say is that the work has to come with expectations of uncomfortable feelings, right? So in everyone. And I think that has, from an educational ethics perspective, we have to, make sure people know that before they, engage in it and so on. But, calling out, I much rather like to call in, right? And to call in really means to engage in a pedagogy of love, right? To know where people are at as you're bringing them in. They're coming from a place where the structures that have existed have created invisibility for them for things that are visible to you, for instance. And, that can be heavy. And, like one of the places where that happens often is, when we talk about when tears happen, when white tears happen, when, in these sessions, and they should happen because it's important to process the heavy emotional stuff of that. But what we all need to recognize, and that's the calling in part, is that white supremacy is such that those tears then become the most important thing in the room rather than the actual issue. And I think that, we have to actually work at just being recognizant of all of that as we're doing our work. So I'll stop there.
If I may add one
Yes,
quick thing.
Sure.
It just made me think of a quote by Dr. Marsha J. Anderson, who says that the pervasiveness of racism in healthcare needs to be outweighed by the pervasiveness of our anti-racism. And really, to me, that guides my view of this, that we need people that are advocating at the government level, at the PHSA level, at the institutional level, at the educational level, but also in direct patient care. We need to have approaches that come from all of these angles simultaneously and relentlessly. And we need to learn from each other, but also not wait for something that works for all of us. The reality of the patients and the workflow in the emergency department is completely different from other clinical spaces. And we need, as clinicians, look at how racism operates in our setting, in our personal lives. And that's, I think, a way to think about anti-racism that is not, let's wait for the Indigenous health team to tell us what to do. No, as Tanya was saying, it is for non-Indigenous people to actually do the hard work. It's not to be put on the shoulders of Indigenous leaders and people, and to add that minority tax again on top of all of the hardship that are imposed on some people. So that's my last thought.
My last sentence will be, you're talking as experts and practitioners in health. I will be under this session with as a patient, we don't come to you because we want to come to you. Sorry. We come to you because we need you as patient, because we are sick, we're not feeling well. So it's not a choice. Sometimes the people who come to you, they have only you. They never even mention their sickness. They don't have family members who can listen to them. They can't even discuss these things. So either you make these experiences with them a life-saving experience, because I know many people who lost their lives because they didn't find the healthcare that is needed at that time in that particular context. You are morally and ethically in this environment committed to save lives. That is, I think, something that we are all working towards. So please, see colors, see experiences, be humble, understand that we all come with our vulnerabilities. We are not all the same. That's why we are seeking a better human healthcare experience for all our citizens, our friends, our colleagues, our Indigenous family here. And I wish that this conversation will open up a much deeper conversations that would lead to real actions. In solidarity with you all, in appreciation for your wisdom and experience and expertise, for all the audience that have made the time to come and attend this session, I leave you with a lot of hope, with a lot of blessings, and Assalamu alaikum, my original greetings to say, peace be with you. Thank you so much.